Welcome. Our program today is on hereditary angioedema, and we will be focusing specifically on inequities of care that exist for patients with hereditary angioedema. And this can include disparities in access to care, making the diagnosis, access to treatments, including enrollments in clinical trials for treatments in hereditary angioedema. My name is Aleena Banerji. I'm a professor of medicine at Harvard Medical School in Boston, Massachusetts. And I'm honored today to be joined by Dr. Timothy Craig and Dr. Marc Riedl. Dr. Timothy Craig is a tenured professor of medicine, pediatrics, biomedical sciences, and OBGYN at Penn State University, Hershey, as well as a senior medical advisor for Vinmec International Hospital, Time City, Hanoi, Vietnam. And Dr. Marc Riedl is a professor of medicine at University of California, San Diego School of Medicine in San Diego, California. These are our disclosures. To briefly introduce you, hereditary angioedema is a rare autosomal dominant medical condition that leads to recurrent and unpredictable episodes of swelling. When these episodes are untreated, the episodes of swelling can last anywhere from 2 to 5 days and are often categorized into peripheral episodes of swelling, which can involve the hands and the feet, abdominal episodes of swelling, and laryngeal swelling. Almost all patients with hereditary angioedema will be impacted by peripheral attacks and abdominal attacks, while approximately 50% of patients with hereditary angioedema will have a laryngeal attack at some point in their lifetime. A laryngeal attack or airway swelling is the most concerning as it can be life-threatening. In terms of treatment, we know that over the past 10 to 15 years, we have made remarkable progress in the development and approval of treatments for hereditary angioedema in the United States. This includes 4 FDA-approved treatments for long-term prophylaxis, as well as 4 approved treatments for on-demand treatment. However, as we will discuss and as the data show, there is still a significant impact on quality of life for patients with hereditary angioedema, and there are significant inequalities which we will focus on today. When looking at the pathophysiology of hereditary angioedema, we know that this is due to a deficiency of the C1 esterase inhibitor protein. This is a key inhibitory protein in the kallikrein kininogen pathway. And when there are low levels or a dysfunction of the C1 esterase inhibitor protein, the kallikrein kininogen pathway does not have the normal inhibition from the C1 esterase inhibitor protein, which can lead to unregulated or increased levels of bradykinin. We know that bradykinin itself is what plays a key role in increasing vascular permeability, and when there are elevated levels, we see an increase in vascular permeability, causing the symptoms of swelling that we see in patients with hereditary angioedema.
Aleena, can you remind us how long the swelling lasts in these individuals and some of the other aspects in the sense of triggers, since we didn't have that on a slide?
Thanks, Dr. Craig, for asking. We know that typical episodes of swelling for hereditary angioedema can last for 2 to 5 days, especially when they're not treated. In terms of triggers and what you hear from your patients, maybe I can ask both Tim and Marc to comment on that.
Yeah, I'll let you go first, Marc. Go ahead.
Yeah, I mean, I think there are certain triggers that are recognized. They include certain medications. We recommend people with HAE avoid ACE inhibitors for certain, which can lead to catastrophic swelling due to the bradykinin increases. Estrogens are a problem, and as we may discuss later, women tend to have a more difficult course with HAE phenotypically than men, although there are severe phenotypes in both genders. And there are also other triggers like trauma, so accidental or iatrogenic trauma, medical procedures like surgery, Dental procedures can really be difficult as they'll trigger severe oropharyngeal or airway swelling. Certain infections may trigger HAE attacks. But one of the difficult things I hear from patients, of course, is that many times there are no clear triggers for their attacks. And I think the unpredictability of this condition is one of the really difficult aspects. These attacks can happen anywhere, anytime, without warning, and that's a difficult way for people to live.
Yeah, that's so the majority of people actually say they can't remember a trigger when you look at the data prospectively, which confuses the issue, like you said.
Thanks, Tim and Mark. I think it was really important for us to highlight those specific triggers, and also the fact that in over 2/3 of attacks, patients actually can't identify a trigger. So let's move on to talk a little bit about the treatment options. And as I had mentioned earlier, there are 8 different treatments that are currently FDA approved in the United States for treatment of patients with hereditary angioedema. There are 4 that are approved for long-term prophylaxis and 4 that are approved for on-demand treatment. In terms of long-term prophylaxis, the first therapy that was approved initially was Cinryze, or a replacement product with C1 esterase inhibitor protein that was given twice weekly. And then more recently, in the last several years, we have Haegarda, which is a C1 inhibitor replacement product given subcutaneously twice a week, as well as lanadelumab, which we know is a monoclonal antibody to plasma kallikrein, and berotralstat, which was the most recently approved in 2020, which is a once-a-day oral tablet. Tim and Mark, how has your experience been in your patients for these long-term prophylactic agents that are approved in the United States?
Yeah, so one of the problems that you mentioned, it's intravenous C1 inhibitor and sub-Q C1 inhibitor work. One requires IV, which is quite a burden. The other sub-Q, which is not too much of a burden, but both of them are every 3 to 4 days. So, the frequency of dosing is what makes them somewhat burdensome. The lanadelumab, has best efficacy when used every couple weeks. You can go out to once a month, but then you miss some of the efficacy. And berotralstat is a tablet, which makes it convenient, but really it's only about 50% effective, where the others approximate 85%. The one thing with that is intravenous C1 inhibitor. If you're just giving it at 1,000 units, you're probably only talking also about a 50% effectiveness or reduction of attacks per month. If you use it at higher doses, the expense increases, but you can get better efficacy. But lanadelumab and Haegarda, or I should say sub-Q C1 inhibitor, are about 85% effective.
Thanks, Tim. I think it's important to highlight the significant efficacy of these treatments, but also that there still remains a treatment burden with using these treatments. In terms of on-demand treatment options, Mark, you know that we have 4 currently available on-demand treatment options. This goes back to 2009 when we had initial approval of ecallantide, which is a plasma kallikrein inhibitor, as well as Tenured, which is a C1 esterase on-demand intravenous treatment. And then in 2011, icatibant, which is a bradykinin B2 receptor antagonist. And then Ruconest, which again is about 10 years ago, which is a recombinant C1 inhibitor. Tell me a little bit from your perspective about these on-demand treatments and how it has been for your patients with hereditary angioedema.
Well, the on-demand treatments are critical, and one of the things we continue to remind our patients is that everyone with a diagnosis of HAE needs on-demand therapy. As you mentioned earlier, this is a life-threatening condition, so not only really debilitating when these attacks hit, but there is a real risk of mortality if the airway is involved. So on-demand treatment continues to be really important to put into our treatment plans. And the good news is we have options, right? Just like the prophylactic medicines, we have a few different options. And so we discuss these with patients, and every patient sort of selects a medicine that's going to be easy for them to use and effective to treat their attacks. And so I think that's one of the themes here is not only do we have options? But there's variability from patient to patient. Not every patient responds exactly the same to each medicine, and side effects might be different in each patient. As you mentioned, I think on-demand therapy is another area where there still is a burden of treatment. These are all intravenous or subcutaneous medicines, and as some recent studies have shown, that is a barrier to treatment in some cases, that patients are either unprepared to treat their attacks or unwilling to treat their attacks because of some of the side effects and discomfort concerns. So as you're going to show us, we have some exciting things in development that may further improve on-demand treatment as well.
The one thing,
Absolutely.
oh,
Go ahead, Tim.
yeah. The one thing I'd add to that, we talked about long-term therapy and we talked about rescue. Really didn't mention anything about short-term prophylaxis, which is important. You know, drug of choice to that is intravenous C1 inhibitor. You can use androgens if you have the time period to stop 5 days before, but that is not as effective as intravenous C1 inhibitor. I think that is the drug of choice, usually given before surgical procedure, especially if someone's going to be intubated. As Marc talked about, that's such an important concept. So if you have a medical procedure passing the airway, again, that would be a time you would want to have a person receiving short-term prophylaxis. And then also for dental work, maybe not for cleaning, that's questionable, but definitely for extractions of teeth, you should really, again, use short-term prophylaxis.
Yes, thank you, Tim. We often forget to talk about short-term prophylaxis, but it's a very important part of managing our patients with hereditary angioedema and really giving them treatment prior to a known trigger, such as a dental procedure or a surgery, where we know that an attack could be triggered by that procedure. You know, in terms of using these therapies, I think one of the things that we often talk about is shared decision making. Is that something that Tim and Marc, that you often will use or think about when you're talking about these treatment options with your patients?
Yeah, I actually go through, as Marc kind of mentioned earlier too, go through the process of explaining the drugs, how they're given, what their risks are. All these drugs have pretty minimal risks, how often they have to be given, and then allow patients to make up their mind. It's still in this day and age surprises me that some people will do intravenous C1 inhibitor as their primary long-term prophylaxis, but I have quite a few young ladies who are very athletic with very low BMIs, and they just prefer, it's easier for them to give an intravenous injection than it is a sub-Q. So yeah, I usually talk about all the drugs. I also talk about all the drugs in research in case people want to come into a research study and let them make the decision. Obviously, there are some times where I try to sway that decision, which depending on the patient, and that's why it's called shared decision instead of patient decision.
Yeah,
Marc, is that a similar approach to you?
Yeah, it's a really important process, and I agree. We use it all the time with every patient. As we know, some patients are more engaged in that process than others. But I do think, as Tim alluded to, I view we're sort of the experts in the condition, but the patients are the experts in themselves, right? And what their preferences are and what's going to work best for them. So we know from other fields that shared decision-making process leads to better adherence, better outcomes. Hasn't been studied extensively in HAE, but in my experience, that's absolutely true. If that patient is active in making their treatment decision, setting up their management plan, they do better and they are more satisfied with the outcome. So I think you can't overemphasize the importance of that.
Yeah, I think just the fact that the discussion itself too is so important for people to feel reassured in what they're doing and realize that you have their concern in mind. So yeah, I agree with you 100%, Marc.
Yeah. And it's not just a one point in time conversation. It's that this is a long-term relationship and ongoing communication and having these discussions at routine, regular follow-up visits that we have with our patients. So to move on a little bit, we all know that there are multiple new therapies that are in development for our patients with hereditary angioedema. And at a high level, just to briefly mention a few of them, for long-term prophylaxis, we know that garadacimab, which is a monoclonal antibody to factor XIIa, so early in the pathway, is in development. We also know that donidalorsen, which is an antisense oligonucleotide, which is actually designed to target the production of prekallikrein, leading to decreased levels of bradykinin. We also know that deucrictibant is being studied for long-term prophylaxis as well as on demand. Navenibart is another monoclonal antibody, which is inhibiting plasma kallikrein, which is in development. There's a gene therapy, which may move the needle forward using CRISPR-Cas9 technology, which inactivates or targets the KLKB1 gene responsible for producing prekallikrein, also mentioned in the pathway. And then sebetralstat, which we know is an oral therapy that would inhibit plasma kallikrein. So again, inhibiting multiple places in the pathway, but leading to decreased activity of bradykinin or decreased generation of bradykinin. Marc and Tim, any thoughts on these products that are in development and how that might move the needle forward or really impact the care of our patients?
Well, it's an exciting time with the continued development of these multiple therapies. And I think that the trend that you're seeing, which isn't surprising, is this recognition that while we do have effective medicines, there's still a considerable burden of treatment. This, at the moment, HAE remains a lifelong condition. It's genetic, and we don't have a cure at this point. So people using medicine month after month, year after year, we do hear that there's a burden. And so a lot of the things that you just mentioned, Aleena, are targeted at, can we find ways to be as effective and as safe, but make it a lot easier for patients to stick with that treatment plan, whether that's less frequent dosing or easier dosing with oral medicines, or in the case of the gene therapy, a one-time dose that would last for we don't know how long, years maybe. So I think that these are, again, exciting times. Of course, these, as you said, these are all investigational drugs. So we have to see where the studies go and what the regulatory bodies think about the data that's produced. But I do think we continue to take steps forward and have more and more impressive options to offer patients.
Yeah, I think the excitement of oral rescue medications is so cool. When you think about two of the rescue medications are IV, one can't be self-administered because of the risk of anaphylaxis, and the other one has a 97% injection site reaction, the ones that are approved for rescue right now. To have an oral medication where you don't have to inject is going to be so good for the patients. I think it might even change some people away from prophylaxis and instead go for just on-demand medication. But we'll see how good the results are when everything's finalized. But also, some of the injections are looking at once every 6 months. And, that'll make a big change to the field of 2 injections a year. If the studies turn out to be as we expect, would make the burden minimal. And like you said, the Intellia drug, it'd be so cool if it is just one injection for maybe your entire life. Who knows? We'll see what happens with that.
Yeah, it's clear that even though we all have seen so much progress in treatment options and even what we have available, that there is so much in development that is going to really move the needle so much for our patients. And so it's really an exciting time, to say the least. But to really bring us back to one of the main things that we wanted to address today, let's think a little bit about the disparities that we're seeing in the diagnosis and management of patients with hereditary angioedema. And this includes the years that it can take to reach a correct diagnosis across the spectrum of patients with hereditary angioedema, access to specialized care, access to therapies, all the things that we talked about. Tim and Marc, maybe I can ask you to talk a little bit or comment a little bit before we go into the data about what you're seeing from your perspective about some of these things and why it's so important for us to talk about the disparities in patients with HAE and how it's impacting their care.
Yeah, I think Mark and I have both written on research studies, and that's really what led me to believe that there's such inequality in for minorities, because in almost all our research studies, it's 90% Caucasian, and there's very few Blacks, few Asians, and very few Spanish-speaking people. Along with that, when we looked at a group of Black Americans, what they showed was that it took about 8.5 years or 8.3 years, which is longer than whites usually say. That is usually about 6.3 years or 6.5. And they also found that they needed, say, 5, sometimes even 7 to 8 doctors as compared to 3 doctors to make the diagnosis. So there is a big disparity there. And I guess Mark will spend some time talking about that now.
Yeah, we'll look at the data that's out there, and I think there's not a lot. This is an understudied area, but certainly in our practice, and I know you both run large centers as well, we see people from many areas, many regions, all walks of life, and you do recognize that where you live, how much money you make, what your insurance is, these things all unfortunately affect access to care and affect the ability to get this specialized care and sometimes the treatment that people need. So anecdotally, I absolutely think this happens. And I think we have some data we'll walk through, but we need more focus on this really as we move ahead. And especially as advances are made, we've got to make these things more equitably accessible to our patients. And that includes the global community, right? I think, Tim, you'll talk a little bit about outside of the US, but this is an area we've got to work on.
To add to that, it is amazing the difficulty for our patients that have Medicaid or Medicare and getting the copay assistance, because all these drugs are $500,000 plus minus a little bit, but close to that. Where with private insurance, at least the pharmaceutical companies pay their copay. And it's usually we are very successful in getting the copay for Medicaid and Medicare patients, but I'm always worried about that amount of money drying up and not being available to subsidize those people who are on state or federal insurance.